Good afternoon, everyone. Thank you all for being here today. We are the Genome BC team, and we're here to present you our project on a comparative analysis of One Health policies in Asia and opportunities for applications in British Columbia. Next slide, please. So for our agenda for today, I will be introducing our project and its goals, and then we'll move on to some guiding questions that our research seeks to answer. And then we'll move on to some findings from our case studies, and then we'll provide some recommendations for British Columbia. So today, British Columbia is faced with the dilemma that public health is deeply connected to the health of humans, animals, and our shared environment. Greater instances of outbreaks, such as COVID-19, as well as climate change and our changing relationship with animals through urbanization, is driving the conversation around the need for a more holistic approach to shared challenges in BC. So Genome BC, a nonprofit organization interested in genomics research, as well as addressing healthcare and environmental challenges in BC, has asked us to look into how the holistic approach of One Health can be implemented in the province. Please. So recognizing the interconnection between humans, animals, and the environment, One Health is a multi-sectoral approach to address emerging public health challenges. One Health conversations are happening in BC, however, they're very isolated instances and are very project or research specific, and have yet to be scaled up at the government level. So by looking to other jurisdictions with One Health around the world, such as Thailand, Hong Kong, Singapore, and Bangladesh, our project seeks to pull in lessons that can help BC in its efforts to implement One Health and help inform how the relevant ministries in the province can better prepare and respond to emerging diseases. So by looking into ways of implementing One Health, our team looked at 4 different case studies in Thailand, Hong Kong, Singapore, and Bangladesh, as these countries have witnessed multiple outbreaks of emerging diseases in recent history, resulting in their creation of functional One Health policies. These countries have also demonstrated to have the highest level of sophistication in terms of their implementation of One Health, with formalized for over a decade. They have formalized programs in place, research mechanisms, and interministerial collaboration for the preparedness and response to emerging diseases. So in our research, we conducted a comparative analysis across the 4 jurisdictions to explore the relevant policy insights that can later be applied similarly in BC. So I'll now pass it on to my colleague Lisa to talk a bit about the guiding questions.
Thank you, Benny. And so Genome BC plays an important role as acting as that bridge between policy and research, and this in turn shaped the questions that we were hoping to answer. So 1, how are One Health policies implemented in Asia? What do these networks look like? And how is research going on to inform policy in these spaces? We were also curious about how these mechanisms are funded and what are the potential strengths and weaknesses of different approaches. And importantly, we wanted to know what lessons can be learned and applied in British Columbia to help accelerate or improve their efforts in One Health. So to go about answering these questions, we conducted a public scan of national strategic action plans, health reports, as well as academic research, and complemented this with 13 interviews. So we primarily spoke to those in research networks and working in government, as seen here in green, across a range of sectors identified in blue. And these people were able to share with us their personal experiences with One Health, as well as their perceptions of the effectiveness within their areas of expertise. So before we get into the nuances of our findings, we wanted to flag 3 foundational things that emerged from our research. So the first is that some level of interministerial coordination is required for the success of One Health policies. Now, this seems really obvious given that One Health by definition is a multidisciplinary approach. However, across all 4 jurisdictions in Asia, some sort of formalized mechanism to cooperate existed. And secondly, this coordination mechanism was grounded in a national strategic action plan that basically called for the One Health concepts to be pulled in when making decisions related to public or environmental health. And third, interviewees stressed the importance of flexible working relationships, such as building a work environment of trust and cooperation, as being more important than other factors such as funding. And so I'll just pass it off to Lindsey to kind of go into this a little bit more detail.
Thank you, Lisa. So this table is essentially a summary of the comparative analysis we did across our 4 case studies. Along the top, we have the case studies, and then along the side are the main parameters against which we compared them. So to start with governance model, or the mechanisms by which decisions were made, there were essentially 2 models that we found, the top-down and the bottom-up approach. In Singapore and Thailand, they utilized a top-down structure. So high-level decision makers like ministers or deputy ministers would form committees that were responsible for implementing the strategic framework on One Health and then directing downwards to the project officer or analyst level on how to go about doing that. A strength of this method is that it is highly coordinated throughout the ministry or amongst ministries. In Bangladesh and Hong Kong, they used more of a bottom-up approach where project officers and analysts would form working groups, some of which would be permanent and some of which would be formed on an ad hoc or as needed basis as emergencies arise. And they would brief upwards to senior level decision makers on, again, how to best move forward or implement the One Health approach given whatever circumstance was happening. Looking to research labs, there was 2 main types that we found. Now, in both cases, they involved multidisciplinary scientists working together. So you would have environmental scientists, human scientists, veterinarians working together collaboratively on projects, but the different type of research lab would shape both the funding mechanisms that they would receive, but also how the research that they were doing was informing policy. So in Bangladesh and Singapore, they had government labs, sort of like a BC CDC lab. And what this meant in terms of informing policy is that information would be fed on a more continuous piecemeal basis towards policymakers because there was a direct link between the scientists and the policymakers. Meanwhile, in Hong Kong and Thailand, you saw university labs. So that would be more like if UBC were to have a One Health lab. And what this meant for policymaking was that the policymakers would consult with researchers on an as needed basis, a little less consistently, or the researchers would produce reports and briefs that would then be used by policymakers. Looking to funding, the thing I want to stress the most is that across the board, funding, there's no silver bullet for funding of One Health. And even for these case studies where One Health has been happening for over a decade, finding consistent funding continues to be a challenge. And so funding is always pulled from a multitude of sources, but we wanted to sort of highlight what the main sources of funding were for each case study. In Singapore and Thailand, there was actually dedicated budget lines within ministries for One Health related activities, which was really interesting and unique. And that meant that the funding was readily there and available to make activities happen quite quickly. In Hong Kong and Thailand, foreign governments actually played a large role in funding One Health activities. In particular, USAID is a very significant actor in this space. And then in Hong Kong and Bangladesh, there's a large space for other international or more local NGOs. And we think a reason for this and a strength of the NGO actor in terms of funding is their ability to be really creative and reflexive and adaptive in what types of projects they're able to fund, which really lends itself well to One Health in that you're trying to be sort of creative in how you respond to problems. Finally, looking at training, we thought this was sort of the most interesting and forward-looking element of One Health in all of these jurisdictions, in that it was sort of shaping the next generation of professionals and just training them in terms of how to think with that sort of One Health mindset. In Thailand, Hong Kong, and Bangladesh, there was a huge emphasis on field training. And so that would be training people who would be out collecting samples, your epidemiologists, and sort of training those folks in how to work with human and animal populations simultaneously. In all 4 jurisdictions, there was actually vocational training available. What we mean by this was there was professional development for policymakers working sort of in the government space. And then in Hong Kong, Bangladesh, and Singapore, there was post-secondary training. So at the undergraduate level, there would be courses available, sort of teaching more like the concepts of One Health, and at times even offering specializations to like a biology or veterinary degree, like in One Health. And Singapore on the far right did offer graduate level training courses in One Health, which was quite unique. So I'm just going to pass it back to Lisa to talk a little bit more about the case studies.
So as Lindsey kind of compared across these case studies, there's also differences between them, in part because of the historical, institutional, or cultural context that kind of make them unique. And so we wanted to flag some things that really stood out to us for each jurisdiction. So in Thailand, this was their utilization of technology, especially when it came to monitoring and surveillance. They use things like apps that are publicly available to help monitor and communicate potential health outbreaks. In Singapore, there is a much stronger integration of the environmental component of One Health, in part because they're trying to build what they call a city in nature, which is essentially pulling in aspects of that natural environment back into urban spaces and thereby increasing the instances people are interacting with their environment. For Bangladesh, there was a much stronger integration of One Health across various levels of government, which is a byproduct of the large amount of NGO support and funding that they had, especially from organizations that have prioritized One Health and helping Bangladesh set up their sort of institutional frameworks. And lastly, we thought Hong Kong most closely resembled the context of British Columbia, specifically that bottom-up approach to informing policy and that consultative relationship between government officials and researchers. And so that kind of concludes our findings. I'll just let Soumya kind of talk about our recommendations a bit more.
Yeah. Thank you, Lisa. We now present to you our recommendations. These stem from the gaps that we identified in the BC context. The first two recommendations in blue are for Genome BC to implement internally. And the third and the fourth recommendation in green are for Genome BC to advocate to the government. We also weighed each of our recommendation on two parameters. The first is feasibility of implementation. This includes financial, economic, administrative, and technical feasibility taken together. And the second is the benefit that the recommendation will create in terms of One Health research, funding, institutionalization, and advancement. A detailed analysis of our feasibility and impact is presented in our final report. So moving on, the first gap that we identified pertains to One Health research. Currently, there is low level of integration among the numerous independent research being conducted in the province. Hence, our recommendation is creation of a university network across BC. This will have two envisaged benefits. First, it will help BC in advancing One Health research. With a university network like the one in Thailand, BC will be able to focus on component-specific One Health research. Second, a university network will provide the much-needed platform for training, capacity building, and development of One Health workforce. The second gap that we identified is low focus on practical projects. Currently, there are numerous projects in the academic and scientific research space, but very few in the applied research space. That is, projects that will have practical outcomes. Hence, our recommendation for Genome BC is to prioritize funding for applied research projects. We also strongly believe that this is a good opportunity for Genome BC because it had previously shown success in its MINC project, which was an applied research project with practical outcomes. The third gap that we identified is no formal coordination mechanism among the multiple actors working in the One Health development space currently in BC. And our recommendation clearly is creation of a coordinating committee that will consist of representatives from the various involved ministries. The coordinating committee will also act as a steering body for One Health development and implementation. And as has been observed in the Asian examples, one distinguishing factors across all the 4 cases that we studied was presence of a coordinating committee within the One Health framework that they nationally adopted. And our last recommendation is to advocate for higher education and professional training. Investment in One Health workforce during early stages of One Health development has shown immense benefit in all the 4 case examples that we have studied. We strongly believe that if BC implements these recommendations, we'll be able to overcome the gaps that we have identified. So in conclusion, we would like to mention that in response to a global pandemic, today organizations like WHO, UNEP, and leaders within these organizations are advocating for One Health as a comprehensive strategy for future pandemic mitigation. We thus believe that this is the most opportune time for BC to step up as a global leader in One Health development and implementation in the current times. We thank you for listening to us, and we are now open to any questions that you may have.
Thank you for that fantastic and very timely, comprehensive, clear presentation. That was a treat to hold and gives us a lot to think about given the current global environment. As per the norms, of course, we're going to begin with a question from Genome BC, and that is from Anita, who is joining us, not in person, I believe, but over Zoom. Anita, I'd like to ask you if you have any comments or questions.
Hi everyone. Thank you so much for the wonderful presentation. I guess in terms of questions, really, how did you find finding information in these countries? Was it what you expected? Was it more challenging than you thought? And did you feel that you reached the right levels to get the information that you were looking for?
I can start. So yeah, for our research, we obviously had our primary research was interviews as well as our literature review. We actually, I mean, depending on each case study, we looked at, because our countries did experience a lot of outbreaks of emerging diseases over the years. I mean, our countries started with like the avian influenza in 2004. So we found that the more experience that they had with One Health implementation, the more sort of information we could find through our research. And then by talking with experts, doctors, people working within the university network, they could also fill in those gaps that we couldn't really find in our research. Any thoughts?
I think when it came to funding, that was a challenge. And I think, I don't want to speak for everyone else, but for me, for sure, I think I expected that. Again, a lot of people reiterated, as Lindsey said, that funding is just like a consistent barrier. And so it takes like a plethora of sources. And it became, some of those were a bit more transparent than others. So Bangladesh, for example, had a lot of international NGO funding. So you could find like project donations that help establish certain like One Health projects. But when it came to the more consistent everyday budget lines like are present in the government in Singapore, it was a little harder to find that information. And then the only thing I would also add is like, I think initially I expected to be able to find sources of funding that we could maybe get an idea of what this costs for British Columbia, but this is so contextual in like how these governments and these situations are set up in Asia that I just didn't think there was any way to like transfer that. So maybe in some ways we can get like an idea of what funding looks like, but I don't know. It was just like, I guess we were left like wanting more.
Probably just a quick addition to what Benny and Lisa have mentioned. I think this was one of our key learnings from the entire project, that unlike other themes for which we got information through secondary sources, funding was one theme which we got most information through our primary source, that is through interviews. And this was a rich addition to the entire process that we underwent. So just wanted to mention this part of.
Thank you for that. And I'd like now to ask Drona Rasali from UBC's School of Population and Public Health if he has any additional comments or questions. Drona was the co-faculty lead together with myself on this project. So I'll pass it to you.
Thank you, Kai, and thank you for the team. Really, first of all, I'd like to thank Genome BC for initiating and sponsoring this project, because Genome BC is very relevant because especially the animal health and human health is tied to genome. And at the genome level, when there is integration, then there is more fundamental work being started. Especially in BC, it is so relevant because we are in an initial phase of One Health concept compared to Hong Kong, which is quite advanced in terms of their number of years of work they have done. They have established the research lab already. You have shown, you have covered so much comprehensive information through the first-hand interview, speaking with the people with their lived experience. I think that's very rich knowledge you have brought in. The question I would like to ask is more about the integration, especially in terms of BC. How you have laid out very well in terms of research. This is what we need to do in the initial phase. Your focus was on research, but at the end of the day, this research has to be translated in the field. It should inform the policy of the government and various levels of government, not just provincial, maybe federal as well, and also local community level also. At the end of the day, if we really want to get the benefit of One Health, we need to have community get involved in the whole process down the road. We may not be there right now. We are just in the research phase. Down the road, we need to have the plan. You as a student of policy science, what's your vision about how we could pull together down the road, maybe in 2, 3 years or 5 years, what we can do to pull the strings?
Thank you for that question. A couple of things come to mind. I think first off, with one of our recommendations, building a university network, I think would be a really great starting point. Our client, Genome BC, has relationships with several key universities like the University of Victoria and of course, University of BC. And so, we put forth that recommendation to them because we felt that because of those existing relationships that they could leverage, they could sort of act as a convener for isolated pockets of research that are currently happening and sort of bring that knowledge together to sort of centralize it and sort of amplify its sort of power and impact in influencing policy. So that's sort of one side of the vision that we had. The other side of it was, with the coordinating committee piece, a really central part of that committee would be developing a strategic framework document in terms of like what that committee would do and how they would direct throughout the key ministries, the Ministry of Health, the Ministry of Agriculture, and the Ministry of Environment. That's something that existed across all 4 case studies that we saw. And so sort of having that guiding document would be a really important first step in terms of actually making the committee happen and making it impactful. Does anyone have anything to add? Thank you. Great.
So with that, we'd like to open it up to questions from the floor, and that includes, of course, anyone in the room or online. If you are joining us online, please use either the chat function, and then Tina will be able to help us with that, or raise your hand virtually. Yes, Melinda in the back.
So interesting analysis. I was just wondering what the incentive of Genome BC was in all of this. Genome BC is essentially an organization that funds research and innovation in genomics. And I was trying to kind of figure out what the hooks were between this more broad, slightly abstract idea of One Health versus an organization that has a very particular mandate. I managed to sort of navigate that.
Yeah, so I think initially they were interested in working with us for sort of
the policy side of things. I know that they're mainly interested in genomics research, but they were also interested in how to incorporate One Health in the province. And they've also already began sort of other projects that have to do with One Health. Mainly being last year, they published a research on farmed mink in BC and their susceptibility to COVID-19 and how to use a One Health approach to mitigating that. So they've already sort of began their research around One Health, and I think they wanted more of like a policy perspective as opposed to like a scientific perspective as to how to actually integrate that within the province.
Yeah, I can add to that. So I think like a key crossover point between genomics and One Health is the ability to sequence the DNA of zoonotic viruses that transfer between animals and humans. And so that would be sort of the scientific side of where the impetus for the interest level is. But yeah, as Benny said, our direct client contacts, George and Anita, are in the Genomics and Society branch of Genome BC. And so what they look at day to day is how genomics research and advancement in genomics research impacts people. And so that was where our project came in, was looking at sort of, if the science is happening at a research lab, what does the people side and the policy side look like?
Thank you.
Thank you. I jumped the gun before. There is actually a follow-up question from Anita as well. So I'd like to pass it back to her to ask that question.
Might not have heard. Back to me. Yeah, no, that was a really great reasoning around why we wanted to do this project. And you're exactly right, on the genomics and society side, we do have to understand the broader policy implications of the research that we do, because of course, we have to have a reason and a justification to be funding projects and to be doing research, and understanding the policy implications, and also how we as an organization can work with stakeholders, including policymakers in this area, just helps advance everything that we're trying to do. So I guess as a follow-up question, I'm interested about your recommendations around training, as there are some programs in Canada that do One Health training, and a lot of it is in the veterinarian space. But would you see, were you thinking of like formal university programs, or are you thinking more targeting professionals already working in this space and sort of like continuing education? What was sort of your, because obviously to create a university program, that's a big funding proposal, and that's quite a large ask. Were you thinking something smaller that would grow, or sort of what were some more thoughts around training?
I can maybe start answering this, and then I'll pass it on to my colleagues. With respect to training, you're right, there are probably two different categories of it. One is the existing One Health, let's say, professionals in it, who, and there's this university program that we spoke about. Probably when we suggest that training should be developed in the region, it's more about in a hierarchy with emphasis on the people who are working on field to be trained more urgently than people who have to be brought into like university courses. And that's because through one of our interviews, we understood like this new perspective that One Health research, there's a lot of focus on the academic side of it, on scientific development of what actually the implication of animal health environment is, but not so much on practicalities. Something like if there is something emerging right outside this building, ground level surveillance is something which is like not as much focused as is the other scientific aspect of it. So if people who work on field in, let's say, public health domain are well trained in this, then this process becomes simpler and easier, and surveillance becomes like stronger in the One Health scenario. So that's why maybe with respect to training, providing training to people on field who work directly in this, like professionals, is more important than, or probably more urgent than those who will have to be brought into freshly into the academic space of it. Yeah.
I could also add that, like, on a smaller, more immediate scale, as Soumya was saying, what we saw in the jurisdictions in Asia is that workshops, and as Lindsey pointed out earlier, is like a really common and really feasible way to introduce like the One Health concept into like a workforce. And then again, as Soumya said, like a hierarchy is I guess at the university level, what we sort of envisioned was like, again, forward looking into maybe a shift in how we think about health. And again, it's like a lot of this happens in like veterinarian sciences usually. But like, how do you pull in that environmental side to it, and like changing the way we see, again, health is like siloed, that it's like integral to the environment, it's integral to our interactions with the environment. And that's just more of like a, I guess like a worldview sort of shift, or like a conceptual shift that kind of just gets people to think about health in a different way, more long-term and like forward thinking again.
Fantastic. And I think we have one more online question from our colleague, Christine Hopewell, and I will ask her to pose it.
Thanks. Thanks to the team for a fantastic presentation, and it seems like a very interesting project. My question is, your project is primarily focused on BC, and I'm wondering if you could speak to the broader applicability of your findings or your policy recommendations to other provinces in Canada, other regions. And also, I'm wondering, to what extent would it make sense to implement some of your policy recommendations at the national level rather than the provincial level? I'm thinking here about, for example, your suggestion to integrate research through university networks. Is that something that would be more effective, at a national level rather than a provincial level? What sorts of broader applications could you see here? Thank you.
Okay. Thank you for the question, Dr. Hopewell. Yeah, certainly. I think in a general sense, absolutely. I think that would be a great opportunity to jump on to, scale up or to consider, the recommendations we've looked at, how they could be applied at a national scale. In terms of what we actually looked at, it was, beyond the scope of the project, because, our client being Genome BC, they advocate within BC and advocate to the provincial government. But of course, if you think about funding mechanisms from the national government through to the provincial governments, or building up a broader university network in terms of being efficient and just effective, I think that would be a really exciting thing to consider. And there's also the reality that if you are looking at emerging diseases and environmental disasters, it's not like they just stop at provincial borders. So, One Health, by definition, is to sort of, broaden your conceptualization of problems and sort of consider the full network. And so I think that it lends itself really well to kind of building a broader network that goes nationally. Thank you. Oh, thank you.
No, I think Lindsey just covered it well, but like she said, because the client's geographical area of operation is BC, that's why our scope was BC. But you're right. So when we looked into our analysis and the recommendations we came up with, the recommendations are like, if we want, we can implement it like Canada-wide. But I think starting with BC is like getting our foot in the door. Once we have a proper One Health example in one province, it's easy to replicate it in others, especially the operational part of it. I think nuances will differ province to province, but majorly something like getting coordinating committee is important in provincial government. And that's something which will be replicated in the federal one also. And I think my idea of this is, it's like vaccination. The more One Health thing happens across province, across like nations, the better we all will be end up with. So yeah. So that's the larger scope of our project maybe, or our inspirations, but for this project, we are limited to BC.